with the panel now, which is the key to prevent the Rh isoimmunization. I have an expert panelist with us and chief experts with us. We have Dr. Poonam Goyal. Dr. Poonam Goyal is a senior gynae consultant at HOD IVF specialty in Max Hospital, Delhi. She's a director and HOD of Panchsheel Hospital. Ma'am has past president of IME EDB and a past member PCPNDT advisory. And ma'am has many awards to her credit and has many books and edited many chapters also in the books. So we go ahead with Dr. Dipti Nabh, ma'am. She's an expert panelist. She's Vice President of East Delhi Gynae Forum presently. She's the Director of Mother and Child Center and a President at Max Hospital, Paparganj and Vaishali. And Dr. Renu Chawla, ma'am, is with us. She's the Joint Secretary of East Delhi Gynae Forum. She's an alumni of LHMC and SSKH Hospital, Delhi. And we have Dr. Uma Vaidyanathan with us. She's a senior consultant for Shalimar Bagh. She's the Secretary of Delhi Gynae Forum North and member QI Committee, AOGD. Welcome, Dr. Uma, ma'am.
Thank you.
Dr. Taruna Dua is our next panelist. She's a senior consultant associated with Akash Hospital, Dwarka. And she is the chairperson Posh Committee, Akash Super Speciality Hospital. She is with us. Dr. Kiran Chhabra, ma'am, next panelist. Ma'am is a senior consultant, gynae officer and director of Chhabra Medicare Center, Pitampura. And ma'am is General Secretary of Delhi Gynae Forum Northwest. She's a member of QI Committee, AOGD, presently. And we have with us Dr. Krishna Gopal. He's a clinical fellow from Singapore General Hospital in Singapore, the fetal medicine specialist practicing in East Delhi. And Dr. Praveen Gupta, she is a senior consultant of gynae. She's a rich experience of more than 30 years. She's a member of East Delhi Gynae Forum. And Dr. Neerja Varshney, she's a senior consultant in East Delhi, associated with Cloud9 Hospital, Paparganj, Bimla Devi Hospital, and Garg Hospital. And she is an executive member with us. So I'll just stop escape this and move on to the next panel. So we know that the key to prevent this Rh isoimmunization is by giving an anti-D at the right time. That is our aim, that everyone of us should be aware of how to prevent Rh isoimmunization so that the next subsequent pregnancy is not affected. We know that it's been 50 years since the Rh anti-D has been developed, and Rh disease has nearly been eradicated in high-income countries where anti-D was widely used. But still, approximately 50% of the eligible cases worldwide, anti-D was not administered. Rh disease still results in more than 160,000 prenatal deaths and 1 lakh cases of disability annually, and only a 50% reduction related to the era before immunoglobulin administration. This is the FIGO publication in 2020. So we have come far away, but still we have a miles to go to prevent Rh isoimmunization. The failure to administer anti-D may be many. It can be an insufficient supply, it can be cost considerations, it can be ignorance, it can be lack of access or use of products that have not been tested for therapeutic efficacy. We have the FIGO 2020 guidelines of prevention of RSD isoimmunization. We have a high priority to give postpartum anti-D within 72 hours of delivery, and middle priority given to the antenatal anti-D, and an anti-D to be given in antepartum period wherever the sensitization events occurs, and a low priority given to the anti-D prophylaxis after amnio or CVS or external cephalic version done during pregnancy. So we move on to the first case, and I request Dr. Uma Vaidyanathan to address this. A lady, she is a 24-year-old, she is recently married and she conceived spontaneously. She comes to us with a report of initial investigation, blood investigation done, which shows her blood group is O negative. And on asking her about her husband's blood group, he says it's same as her wife. So what should be done in this patient? The husband says it's the same blood group as wife, O negative. What will you do to ascertain the Rh incompatibility in this case, and whether you will advise her ICT, Dr. Uma?
Yeah. Very good afternoon. First of all, hearsay as far as blood group is concerned is not something that I would like to advocate in any way. So if a patient tells me that she's O negative, I would ask her for a documentation of her blood group first. If her blood group is O negative, I will ask her husband or her partner to get his blood group documented from a standard lab. It is very important in these cases. We cannot ignore the possibility of the fact that the patient may erroneously mention her blood group as positive or negative. That can have a very deep impact on her pregnancy later on. Secondly, any patient who is Rh negative, you will definitely ask for any previous history of a pregnancy, for any previous history of a blood transfusion. The usual history that we generally would ask in an Rh negative patient, we will ask. But documentation of blood group is essential in these patients. So I would definitely not go on hearsay. I would ask them to show me a proper documentation of the blood group, both for the husband as well as the wife. And in these cases, and if both the husband and wife are O negative, I do not see the need to do an ICT in these patients. The message that has to go out very clearly is that if the blood group of the mother-to-be is Rh negative, O negative or Rh negative, and her husband is also tested Rh negative, there is no need for further testing in these patients. We are not expecting any adverse outcome related to Rh isoimmunization in these patients, even if the mother is Rh isoimmunized because of whatever reasons, the baby will be unaffected.
Very true, Dr. Uma. I think it has to be documented very well, both the husband and wife blood group, that they both are negative in order to decide that ICT is not required and we can carry on. Because even if the ICT is positive in such a situation, in case that patient had received a blood transfusion early or sensitized because of some other reasons, if the fetus is Rh negative, then it is not going to affect the fetus RBCs. They are not going to get destroyed. So there's no point in doing an ICT once we know the blood group. But in case if the husband is erroneously telling that the blood group is O negative, you found out the report is O positive. In fact, it's an ABO compatible blood group. And whenever we have an ABO compatible and Rh incompatible blood group, then the chances of isoimmunization, in fact, is much more than the ABO incompatible blood group.
Definitely.
Make sure the husband is the partner. I think ICT should be done in all the patients because paternity can always be an issue. I have experienced in two of my patients. So what's the harm in doing ICT?
And then there could be other blood group abnormalities also. ICT is better.
Better to do.
But if the ICT is positive and the fetal is Rh negative, then fetus is not going to get affected by the ICT detector.
Yes.
We move on to the next case. She's a primary gravida at 8 weeks pregnancy. She presents with spotting TB. Her blood group is B negative. Husband is B positive. Her ICT comes out to be negative. She is not sensitized. How will you counsel this patient? Does she require an anti-D? If she requires, what is the dose? Dr. Praveen, can you please deliberate on this?
Good afternoon, everyone. Yeah, as the patient, she is a primary gravida at 8 weeks of gestation with just a slight spotting per vagina, and her blood group is B negative. ICT turns out to be negative. So according to the FIGO guidelines, in case the gestation is less than 10 weeks, then we can manage the patient conservatively, and she does not require any anti-D dose. And then we can counsel her, we can repeat her ICT every monthly and see the titers accordingly. In case she lands up with increase in bleeding per vagina associated with pain and her gestation is more than 10 weeks, she has to go for a surgical evacuation. If the gestation is less than 10 weeks and medical management, then we can inoculate her with an anti-D, and the dose is around, since the fetal-placental volume is usually less than 3 ml, around 3 ml or so. So we can give her around 50 to 120 micrograms of NTD, because each 10 micrograms of NTD neutralizes 1 ml of fetal blood. So because the fetal-placental volume is less than 5 ml, it is around 3 ml. So 100 micrograms is sufficient in case we go for surgical evacuation before 10 weeks or medical management after, in case that.
Dr. Praveen, would you give anti-D in this patient 8 weeks, only a single episode of spotting?
No. Now, I'll like to manage her conservatively. Just wait and watch. It is just a spotting. It will subside with other medical management. I'll not like to go for an anti-D at present.
But she can have subsequent bleeding or spotting.
In case she has subsequent bleeding and spotting, then I'll if I have to go for a surgical MTP, then I'll give her an anti-D. In case she doesn't land up with the surgical MTP and she continues the pregnancy, then repeat titer after 4 weeks.
RhD antigen on fetus can develop as early as 7 weeks.
7 weeks, yeah.
Right, and about 3 to 11% of women with threatened abortion in first trimester have fetal maternal hemorrhage, but they are mostly in between 10 to 12 weeks of pregnancy. The total fetal placental blood volume at 12 weeks is 3 ml or 1.5 ml fetal Rh, which is easily neutralized by 100 microgram of anti-D. There are the various professional bodies which have recommended in spontaneous abortion, threatened abortion, anti-D prophylaxis. While the FIGO says that anti-D 100 micrograms should be given after surgical abortion or an ectopic or after spontaneous or medical abortion after 10 weeks of pregnancy. This is the FIGO 2020. Basically, the guidelines say that less than 10 weeks of threatened abortion, the chances, the risk of immunization is very, very low. But we must be very judicious and cautious in such patients. If she can have a recurrent episode of spotting and she can get sensitized later on, there is no harm in giving an anti-D at this gestation.
So, Dr. Meenakshi, so what is our takeaway for all of them? That if for 8 weeks with spotting first episode, are we giving or are we not giving?
No, we are not giving.
What is the final?
Take-home message is single episode at 8 weeks, she may not require, but she can have a subsequent spotting.
If she has repeated spotting, then
patient has to be counseled that if she has again a spotting, then better to give an anti-D. It depends upon the amount of bleeding patient is having.
Right.
So what are the sensitizing agents which can lead to RS sensitization further during the course of pregnancy? What is the amount of fetal-maternal hemorrhage during sensitization events? And is it covered by anti-D of a dose of 300 microgram? Dr. Dipti ma'am?
So good afternoon, everyone. I would like to thank the organizing team, Dr. Jyoti Bhaskar and Dr. Meenakshi for giving me this opportunity. And before I answer part one of this question,
तो उधर ही मतलब ढूंढना पड़ेगा पास है.
Okay, so let me start. I would like to make 2 comments. One is that RH sensitization can occur even without non-exposure to a fetal RH positive RBCs, like say in a mismatched blood transfusion, even in a bone marrow transplant. Because even though in a bone marrow transplant, the bone marrow is centrifuged to remove the antibodies without harming the efficacy of the stem cells. Nevertheless, it has been found that in an Rh negative recipient, she receives bone marrow from an Rh positive donor, can develop anti-D. So these things have to be kept in mind. And coming back to Rh isoimmunization of a Rh negative mother, supposedly carrying an Rh positive fetus, please remember that this immunization can occur even without a sensitizing event. A kind of a silent fetal-maternal hemorrhage can occur anytime during a pregnancy, and though the event are more in the 3rd trimester and during labor. So that is the reason why antenatal prophylaxis is suggested in a non-sensitized patient. To make things easy, let us focus on events which occur in the first 12 weeks of pregnancy. So all invasive procedures like chorionic villus biopsy or embryo reduction, then coming to an ectopic pregnancy and a mole. Now, mole, irrespective whether it is the partial mole or a complete mole. In a complete mole, what happens is there is no organogenesis, so it doesn't actually need any anti-D, but then one doesn't know, and it is what we learn from our seniors to be prudent, wiser to give an anti-D rather than to confirm whether it is a complete or a partial, and then evacuation. And if it is a planned evacuation, surgical or medical, I in my clinical practice always give anti-D, irrespective of the duration of pregnancy. In a threatened abortion, we just had Dr. Praveen Gupta deliberating on this particular question. So if it's the FIGO guidelines do mention till up to 10 weeks, it is not required. But if the same patient had come with the bleeding and a pain, I would give her, because I would rather give her than hold it and then, regret my decision. And the same is with medical abortion, surgical abortion, threatened abortions, and of course, spontaneous miscarriages. Again, the guidelines mention up to 10 weeks doesn't need, but beyond 10 weeks, yes, anti-D is given. Coming to events which are after 12 weeks of pregnancy. So if there is external cephalic version, which I don't think I've done in the last 20 odd years, then amniocentesis, if there is a placenta previa and there is a bleed. If there's a repetitive bleed, then after every 6 weeks, then in case, what I have gathered is that after 6 weeks, you may have to repeat the dose. And in cases of abruptio placentae, accidental hemorrhage, then yes, it is a sensitizing event. And then of course, delivery, whether it is a normal delivery or a cesarean section, and blunt traumas. Now, there are certain clinical situations where you anticipate a large fetal-maternal hemorrhage, say like in IUD, in cases of a blunt trauma in the 3rd trimester of pregnancy, in twin deliveries, in manual removal of placenta, like Dr. Deka just mentioned, any traumatic delivery, even in cases of unexplained hydrops. Here, you anticipate it is going to be a large amount of fetal-maternal hemorrhage, and these are the patients specifically who need higher dose. Coming to the second part of the question, what is the amount of fetal-maternal hemorrhage which occurs during these events? So, all these events which occur before 12 weeks, the amount of fetal blood which you find in maternal circulation is generally about 0.07 cc, and this increases then from onwards to up to 0.19 cc at delivery. Now, a standard dose of injection anti-D covers up to 30 ml of fetal blood, or we say 15 ml of fetal RBC. So that very well covers. So in approximately 96% of women who are Rh negative, and if they're carrying an Rh positive fetus, are very well covered with one single standard dose. And the same goes for a shorter, smaller dose, which covers almost all the events in the 1st trimester. But like we may not be doing a KB test or a Rosette test, but that doesn't mean that we should be not doing about it. And even if you're not doing, like just mentioned, and where you're anticipating a large hemorrhage, then second dose is a must.
Thank you, Dr. Dipti ma'am, for explaining it in detail. And I think this is the take-home message which, after this presentation, that we should all remember, that 300 microgram of anti-D neutralizes 30 ml of fetal blood cells or 15 ml of fetal RBCs. And 100 microgram of anti-D neutralizes 10 ml of fetal blood cells or 5 ml of fetal RBCs. Though usually at the time of delivery, around 96 to 98% of the deliveries, the fetal-maternal hemorrhage is usually less than 5 ml, and which will be adequately covered by the 300 microgram of anti-D. But there are going to be certain situations where fetal-maternal hemorrhage is going to be more. We need to identify them and then manage them accordingly. We will be dealing with in detail later. Just a minute, sorry. And another thing which I want to highlight is that the potential sensitization event which occurs in less than 12 weeks, 100 microgram dose should be given. Any event more than 12 weeks of gestation, if it occurs, then best is to identify whether it's a small fetal-maternal hemorrhage or likely to have a large volume fetal-maternal hemorrhage. And then at least a dose of 300 microgram of anti-D should be given. If we are suspecting more, then an 10 microgram of additional dose for every additional 0.5 ml of fetal RBCs in the maternal circulation to be given.
Is 100 micrograms available in the market? I don't think so. 150 is available. 150 is available generally.
Okay. Yeah. Previously it was available.
Not so easily. 300 is the most commonly
300, yes, 300 is the most commonly available.
Yeah, 150 also you can get. You don't get it. 150 you get. Not very easily, Dr.
But there is no harm in giving more rather than
rather than holding it back.
Yes. Right. So if 300 is available, give 300.
Yeah.
What are the recommendations? Yes, ma'am. Dr. Taruna, ma'am. What are the recommendations for anti-D to prevent Rh Isoimmunization in a patient who is Rh negative and ICT negative? What is the antenatal dose, period of gestation, postpartum dose? There's any time frame? Though we have discussed, but I want you to highlight.
Yeah. So this is the most common which we come across patient is Rh negative, husband is positive, and ICT is continuing to be negative. So we have to give a routine prophylaxis so that she does not develop isoimmunization. And for that, what is recommended is that we give her a single dose of 300 micrograms of anti-D at 28 to 32 weeks of gestation. Here we have a second option, which has been quoted at many places, that we can also give 2 doses of 100 micrograms each. The first dose at 28 to 32 and the second one at 30, the first at 28 and the second at 34. But at the end, what we generally accept and which gives a better protection is the single dose of 300 micrograms at 28 to 32 weeks of gestation. Then this covers the antepartum period, and if we have any sensitizing event in between, that is different, that is to be handled separately. And supposedly if the pregnancy is continuing to be normal and we have a delivery, and then we should be giving her the postpartum dose of 300 micrograms again. Here I would like to highlight, we should give it as soon as possible, definitely within 72 hours. And the place where it should be given is preferably the upper part of the deltoid or the anterolateral aspect of the thigh, because here the absorption is faster. So it will give her a better protection rather than giving it in the gluteal region where the absorption is a little slower and the protection will come later and may not give her full protection also, probably. And the second thing is that supposedly if we miss, because of any reason we are missing the dose of anti-D, then maybe if we have passed 72 hours, we should still give it maybe up to 9 to 10 days. And even some studies have said that even up to 28 days, whatever benefit we are able to give her, we should still be giving her a dose of anti-D.
Very well said. Dr. Taruna, ma'am, ideally it should be given as early as possible, as early as we know the blood group of the baby. If it is positive, we need to administer the anti-D, and 72 hours is the window period where the maximum efficacy and the least sensitization occurs. But if we miss this deadline of 72 hours, it can be given as late as 28 days of delivery. Earlier the better.
Right. And anything where we feel that the feto-maternal hemorrhage has been more anticipated, manual removal, any of those events, manual removal of placenta twin, then again we have to escalate the dose according to calculation of the feto-maternal hemorrhage.
Yes, ma'am. Very well said. We move on to the next question. What is the risk of Rh negative, ICT negative patient if she misses her antenatal anti-D, but she gets to receive the postpartum anti-D? And is the risk different if she misses both the dose of anti-D, if she had not received anti-D, antenatal as well as the postnatal? Dr. Neerja, ma'am, what's the risk?
Hello. Yeah.
Yes, ma'am. You're audible.
If she misses antenatal dose only, then still she has a chance of getting isoimmunized in her next pregnancy to the tune of 1 to 2%. Because spontaneous feto-maternal hemorrhage occurs during the first trimester and second and third trimester. And as per the studies, it has been seen that 1 to 2% are sensitized during first trimester, 7 to 9% are sensitized during the third trimester. And by the end of at the time of delivery also, if patient has not received the anti-D, she gets sensitized to the tune of 7 to 9%. So overall, if she misses both of anti-D, then she has a risk of about 17% for her next pregnancy. But if she receives only postpartum anti-D, then she has a risk of about 1 to 2%. And it has been seen by FICO guidelines and by the surveys that still we are not using antenatal anti-D. The awareness is very less for antenatal anti-D, and it is to the tune of 10 to 20%. And by giving antenatal anti-D, still patient can get sensitized, and that is the risk has been reduced to 0.18%.
Yes, ma'am. Postpartum prophylaxis within 72 hours decreases the risk of Rh immunization right from 16 to 1.5%. And if we add antenatal anti-D as well as the postpartum anti-D, the risk is further reduced to 0.5%. Single dose of 300 microgram is recommended at 28 to 34 weeks, better than the 2 doses at 28 and 32 weeks, according to the FIGO 2020 guidelines. So we move on with the next question. What are the measures to be taken during delivery of Rh negative non-sensitized pregnant women to decrease fetal-maternal hemorrhage and sensitization? This has been very beautifully answered previously by Dr. Deka ma'am, but I would like you to deliberate, Dr. Praveen, so that we do not let the fetal-maternal hemorrhage occur and decrease the sensitization of such women. Dr. Praveen?
First of all, labor should not be induced in these patients. Secondly, continuous electronic fetal heart monitoring is to be done. No stripping of the membranes should be done because it might lead to a subtle fetal-maternal hemorrhage. Then in the first and the second stage of labor, no uterine fundal pressure or pushes should be encouraged. Then in the third stage of labor, as soon as the baby delivers, prompt clamping of the cord should be done on the fetal side. The maternal side, as explained by Dr. Deka, should be left hanging so as to drain out the blood from the placenta and lead to, in that way we can decrease the chances of sensitization. Then active management of the third stage should not be done because it increases the uterus. If we give oxytocin or if we give methogen, then it will lead to squeezing of the uterus and more fetal-maternal hemorrhage. More fetal blood is pushed into the maternal circulation. Then in case PPH happens, then we have to use, or we prefer oxytocin over methogen. We should try to protect the vaginal lacerations and etc. from the spillage, fetal spillage from the umbilical cord, so that less exposure to the fetal blood takes place. Then a longer end of the umbilical cord should be left attached to the baby in case the neonate goes for a exchange transfusion. And in case of cesarean sections, we have to pack the abdomen so as there are less chances of fetal blood absorption taking place through maternal lymphatics, etc. And as soon as the baby is delivered, we have to take a blood sample and send it for direct Coombs test, hemoglobin, hematocrit, serum bilirubin, etc. and blood group as well. And then monitor it accordingly. We have to evaluate, keep clinically assessing the neonate for any development of pallor, anemia, or jaundice. And early discharge is not indicated in these neonates. And we have to encourage the mother to breastfeed the baby, the neonate, so that there are less chances of dehydration, which might, in case of hemolysis, might increase to increased levels of bilirubin.
Yes,
I think that sums up everything.
Yes, very well summed up, Dr. Praveen. The thing is, there should be no oxytocin use before to delivery of placenta. And we should not be doing fundal pressure during the delivery. And the spillage of the cord blood should be avoided at the perineum where the episiotomy is there. There should be clearly, the cord blood should be draining away from the episiotomy site. And even during cesarean, apart from the packing of the gutters, we should be suctioning out all the blood and the liquor from the maternal abdomen. And maybe a peritoneal lavage after the cesarean, I think, will decrease the amount of fetal blood in the maternal cavity. We move on to the next case, Dr. Renu ma'am. A 24-year-old lady, she recently married, self-administered MTP pills for 2 weeks of missed periods. She never got any investigation done, just popped some MTP pill while she was 2 weeks overdue. And she comes to us 3 weeks later with irregular bleeding. Ultrasound shows retained products of conception, and the blood group which we advised at that time came out to be negative. Will you administer NTD? What are the risks of RHS immunization in this patient? Dr. Renu ma'am.
Although her blood group is Rh negative, we need to know the blood group of her husband. In case he is also negative, then we don't need to do anything. In case husband's blood group is Rh positive, then we need to give her NTD in the dose of 100 micrograms. Although all of us know that the rate of sensitization in first trimester is very low, to the tune of 1% only, and she has come after 3 weeks, still we have a window period, because recommendation is that we can give NTD up to 28 days after the event has occurred. So I will like to give her NTD in the dose of 100 micrograms. And Rh isoimmunization in the first trimester is very less, in the tune of 6 to 7% only, and the volume of blood which is there is only 0.07 ml. So with all these low values, the risk of sensitization is only to the tune of 1%. But still we don't know, since she is a primey and she has to have more children later on. So NTD should be definitely given to her. And all abortions less than 12 weeks, whether they are medical abortions or surgical abortions, they should all be given a dose of NTD of 100 micrograms.
Yes, ma'am. Over-the-counter patients just pops MTP pills, just like a method of contraception rather than abortion. And many a times we don't know whether this was her first MTP or she had already taken a medical abortion prior to this. So I think we should always do an ICT also to see whether she has not been sensitized already. If she is not, we should administer NTD. Maybe we are able to give her only after 3 weeks when she comes to us, but there's no harm in giving an NTD. It's going to prevent the sensitization further. We come to the next case. Primary Rh negative, ICT negative, comes with an ultrasound report of intrauterine fetal death at 26 weeks of gestation. So, ma'am, Neerja ma'am, how will you prevent Rh isoimmunization in this patient? If Cleobetke test can't be done, how will you determine the dose of NTD?
You have not mentioned the blood group of the husband. If husband is
positive,
then if she comes with at 26 weeks with ICT negative and IUFD report, ultrasound report, generally we think that it is because of fetal-maternal hemorrhage the IUD has occurred. In such cases, to assess the fetal-maternal hemorrhage, we would like to do the KB test, which is generally not done in our scenarios, like we are not able to do in India. And these tests are generally not done in very few centers. So to prevent isoimmunization in such cases, it is recommended to give full dose of 300 micrograms so that sensitization is not occurring and we can prevent isoimmunization in such patients.
Yes, ma'am. In fact, these are the situations of fetal-maternal hemorrhage which is going to occur in large volume. Many times, if the intrauterine fetal death occurs, the fetal-maternal hemorrhage may be more than 30 ml and it can go as high up 80 to 180 ml, which has been recorded in literature. And at 26 weeks, it's about 800-900 gram baby. It's going to have a liter of blood. So we really need to ascertain how much is the fetal-maternal hemorrhage, and best is to do a Cleobetke test. And it's easy to do. 80% ethanol is usually available. We just have to wash with 80% ethanol. And just basically the fetal RBCs, they will be standing out against the maternal ghost cells after when we stain with HNE. And the ratio, we should determine the amount of fetal-maternal hemorrhage through Cleobetke test. I think that is the ideal scenario in this. But if it is not there, then the sensitization cannot be prevented by one dose of NTD. So we must know that these are the situations where we may need to need more amount of NTD. So the situations can be risk of fetal-maternal hemorrhage bleeding, which is greater than 30 ml, can occur in cesarean sections. But fetal death, intrauterine manipulations, placental abruption, placenta previa, and MRPR situations, which will lead to fetal-maternal hemorrhage, which is more than 30 ml. There is one study where they have written that the indication and doses of Rh immunoglobulin should be given 300 microgram for all third trimester sensitization events, but bleeding after 12 weeks, antepartum hemorrhage beyond 12 weeks, fetal death, maternal trauma, placental abruption, it should be calculated according to the percentage of the circulating fetal red blood cells.
Dr. Meenakshi, for cesarean, you use the word cesarean for more than 30. So is there a specific type of cesarean or certain things under cesarean, but all cesareans we're not going to give more than?
No, ma'am. All cesareans, there was a study which shows that 98 to 99% of the cesarean, the total fetal-maternal hemorrhage estimated was less than 5 ml.
Yeah.
there are only less than 1% of the cesarean sections which will have a fetal-maternal hemorrhage of more than 30 ml. In Western countries, in Netherlands and all, their studies, they do clear bed kit test after each and every cesarean. And whenever it is more than 30 ml, they give an extra dose of anti-D. So this...
We can't generalize for a cesarean section. Like
yes, no,
Meenakshi, generalized.
If you're doing a cesarean for a placenta previa, you're cutting through the placenta.
That is different, ma'am.
Yeah, if you're doing a manual removal over there, of it's an accidental.
That would be, yeah. Those are higher risk. We are talking, ma'am, we are talking of routine cesareans.
Routine you can't do. Yeah. Please.
Deka ma'am, you want to make a comment? You were saying something.
No, I think it's okay. Like routine, you don't really need to worry much. But make sure that you have this tendency of putting your hand in and removing the placenta. Don't do that.
Yes, ma'am. That is the thing. So that one study which has shown that 99% of the cesarean sections, the fetal-maternal hemorrhage is less than 5%. So 300 microgram dose is going to be sufficient. But in situations where we expect more fetal-maternal hemorrhage, where intrauterine manipulation has been done, MRP, placenta previa, those are different scenarios where it has to be individualized. So clear bed kit test is basically the test which we all should know, that the percentage of fetal blood cells relative to maternal red cells multiplied by 50 is equal to the amount of fetal blood volume in the maternal circulation. This is a simple formula and it's simple to do. I think we should get hold of our laboratory persons and get this clear bed kit test done. It can be done in any lab. This is the FIGO 2020 guideline, which says that anti-D prophylaxis after bleeding, abdominal trauma, and of fetal death. During second or third trimester, clear bed kit test should be used to estimate optimal dose. The optimal dose in prenatal hemorrhage in second and third trimester is not known, but 300 microgram should be most commonly used. Because an IUFD has been caused by a large fetal-maternal hemorrhage, it may be a useful option to perform a clear bed kit test, both as a part of workup for fetal death and among RSD negative women to determine the amount of fetal-maternal hemorrhage to calculate the dose of anti-D, and additional 10 microgram neutralizes 0.5 ml of fetal RBCs. This we should all remember. So we come to the next question. Primary gravida RS negative ICT negative patient with fibroid uterus underwent emergency LSCS. MRP has to be done in this patient. I think we already discussed this. We move on to the next question.
Nahi, Meenakshi, I want to say something.
Okay, ma'am. Next question.
I think we have discussed it a lot of times, but one thing should be in our mind. 1 ml needs 10 microgram. 1 ml of whole blood is equal to 0.5 ml of RBC. So sometimes you get confused with 0.5. Whole blood is 1 ml. RBC is 0.5 ml. And to neutralize both these, we require 10 microgram. 10 microgram is equal to 5 international units. 50 international units, I mean, 50. Because of the injection we use is of 1500 international units. I think you should not get confused with international units, because some of the FIGO papers and all, they use units, but we use microgram. I think microgram is well enough for us, and whole blood microgram 1 ml 10 microgram. That's all. And clear or bed kit test, if not done, then as madam suggested, if you think you have done a lot of procedure, there has been a lot of time to separate the placenta, then to be given. Otherwise, one is okay. 4 bleed occurs, traumatic, if you would say. But if
Dr. Poonam, आप कहीं
traumatic, then also utilizing 30 ml with a tangy.
आप फ्लाईओवर पे हो, डाउन चली गई. So mathematics is very difficult. So all we need to know is that you just give double the dose if you feel that it is more.
Yes.
That's
yes,
more.
That's more. Most of the cesareans, they have shown that the maximum fetal maternal hemorrhage which occurred is about an 80 to 130 ml. So if clear bed kit test is not available and we feel that this will not be adequately covered with 30, there is no harm in giving an extra. In one study, they have in fact estimated and given up to 7 vials of 300 microgram. And we must remember that whenever we need to give large doses of anti-D, and then we need to give it intravenous. And what they have, this is also, I feel like it's important to share, that they had given the anti-D within 72 hours, in fact, within 24 hours, and after 48 hours, they have again checked the Clear-Bedke test done. And if the fetal RBCs were still present, they had given additional doses of anti-D.
So the calculation of dose of anti-D, if we are giving IV or IM, is different. For IM, it is 125 international units per ml. And for that, I think it is 62.5 or 67.5.
That means half
when we are giving IV, when we are giving nearly half the dose.
Half the dose.
Yeah.
Okay. So we move on to the next case. She's third gravida, Para 2, no living issue with Rh negative pregnancies. And she did not receive anti-D in any of the previous pregnancies. She is now 10 weeks pregnant. So how we should monitor this patient? What should be done? Dr. Kiran Chhabra, ma'am?
Yes, thank you. In this case, because we don't know about the blood group status of her husband, we should definitely document that first, that whether he is positive or negative. If the husband is negative, then we don't need to do anything. But if the husband is positive, then we have to see whether this woman has been sensitized in previous pregnancies or not. For that, we will go for an ICT test, which we will be doing at every 4 weeks if it comes out to be negative. But if this ICT test comes out positive in 1:16 dilutions, then we will repeat this test every 2 weeks. But if it comes more than 1:1:16 dilution, then definitely we will have to go for some further testing to know the exact status of the fetus, whether the fetus is developing anemia or the baby is going into high drop status. For that, we will go and we'll do a ultrasonic test, ultrasound test, in which we will do a middle cerebral artery peak PSV determination to find out whether the baby is anemic or not. Because MCA PSV is 100%, it is, I will say, gives the response that if it is positive, it shows that the baby is anemic. So this we will be doing at 4 weekly interval. But if this MCV PSV comes more, and that 1.5 moms or more, then this has to be repeated every week. And if it is coming more every week, then definitely we will have to go further with doing cordocentesis and finding out what is the status of the baby. In that case, if the hemoglobin is less, to find out the hemoglobin of the baby. In that case, if it is less, then we'll definitely refer the baby for IUT. And if not, then we will keep doing MCA and PSV testing so that up to 35 weeks. And at 35 weeks, after giving a steroid cover, we will deliver the baby.
Very well explained, ma'am. We need to determine the isoimmunization status of this patient. If ICT is negative, we manage it as a normal ICT negative pregnancy. 4 weekly ICT, antenatal anti-D at 28 weeks, and then postpartum anti-D according to the blood group of the baby. But if she comes out to be ICT positive, then we need to see whether the ICT positive is low titer or beyond the critical titer. Critical titer basically is the titer below which none of the fetus had developed fetal anemia, and it can vary from lab to lab. And usually it is taken 1:16. So if it is like 1:8, 1:16, we monitor it 2 weekly. And if the ICT titer, whenever it's beyond critical titer, simultaneously we also need to be doing the ultrasound, and we need to see the MCA, PSV, MOM in this patient and manage them accordingly. So I will not be deliberating further on this because we have a next question which will deal with this similar situation. So this is a third gravida, Para 2, both cesareans done, Rh negative, anti-D given after both deliveries. She has a history of transfusion in the last baby. Now she is 19 weeks ICT positive. Titer is 1:128. What was the reason of sensitization in this patient? And how should this patient be managed?
as we know,
Renu Chawla, please.
that it has already crossed the critical level of the titer. It is already more than 1 in 16. So this patient is already, this pregnancy is already sensitized, in spite of the fact that she has received NTD in both the pregnancies. So the reason for sensitization may be that the NTD was given not given at the proper time. She was not given NTD, plus postpartum NTD was not given on time. Thirdly, we don't know the detail of the cesarean, whether the cesarean was done in emergency and whether she had APH or PPH and how they were managed. And quality of NTD given, we cannot be sure of whether the storage was proper or not and the dose given was sufficient or not. All these are the reasons, or whether she received blood transfusion in that pregnancy, in the last pregnancy where the baby also received exchange transfusion, because there must be some events which has caused sensitization to the tune of 1:128. So all these events we need to know from the detailed detailed obstetric history. So once we know that she has already crossed this critical titer, so this patient should be handed over to the fetal medicine people, because she needs more extensive monitoring so as to know about the middle cerebral artery, and PSV readings are to be taken बहुत जल्दी करना पड़ेगा, means every week or maybe twice a week we need to do it, this fetal monitoring. And once we see that the fetal anemia is severe, that this baby will require intrauterine transfusion. So for all this management, it is better that this patient is handed over by this patient is treated by the fetal medicine experts.
Yes, ma'am. ICT positive beyond critical value, very high chances of this pregnancy in leading in fetal anemia. But we don't know that this pregnancy itself is an Rh negative fetus or Rh positive, as the father may be heterozygous. So we need to see the ultrasound parameters of fetal anemia in this patient and decide accordingly. So Dr. Poonam, we refer this patient to you now. So what are the ultrasound features? Yes, ma'am.
One thing I would like to add about ICT, just a revision and benefit for the benefit of everyone. ICT in the titer, what is the meaning of titer? It means that it is the dilution, maximum dilution at which the agglutination is taking place. In this, what is done in indirect womb test, the maternal plasma is incubated with the known with the known Rh positive cells. So any antibodies present in the maternal plasma will coat the known Rh positive cells. Then this sample is washed and then it is suspended in a Coombs serum. Coombs serum is anti-human immunoglobulin. So whatever fetal RBC are bonded with the anti-D antibodies in maternal plasma, the anti-human globulin will bind to it and agglutination will occur. And 1:16 or 1:20, 128 means that one part of the maternal plasma, if diluted 16 times or 128 times, so that is the amount of antibodies present, and agglutination will occur at so much of dilution. So higher the titer means more number of antibodies present and more chances of a higher degree of sensitization and more the babies at risk. Thank you.
Yes, Dr. Praveen. The higher the titer value, the larger the amount of immunoglobulins already present in the maternal blood, which are going to get transferred to the baby and going to lead to fetal anemia.
The baby.
Yes, but it does not correlate with fetal anemia very well. We should not always be going by the ICT titer alone. Once it crosses the critical value, be it 32, be it 64, be it 128, we should manage it as per the ultrasound features. So, Dr. Poonam, ma'am, what are the ultrasound features of Rh Isoimmunized pregnancy? And there are some ultrasound features which are detect the fetal anemia early, and while some are the features which we say that this is a severe fetal anemia and is going to have a worse perinatal outcome until and unless IUT has been given soon. So, Dr. Poonam, ma'am, will you elaborate?
Yes, the amount is because of all that, because of the hemolysis, there is solution and there is less of there is anemia in the fetus and there is hypervolemia in the fetus. Because of this hypervolemia, the third compartment of the fetus, in all the cavities, slowly, gradually, the fluid will start accumulating, especially in the abdomen, and then in the pericardium, and then in the pleural cavities also. And slowly the generalized anasarca will be there. We define that hydrops is whenever there is generalized anasarca and fluid in one of the compartment, or free fluid accumulation in two of the compartments. But as gradually the disease progresses, there will be fluid everywhere in the fetus, and gradually there will be hepatosplenomegaly, and the decompensation of fetal heart will take place, and then this will lead to fetal death. So these are the features of, and one thing I would like to add, that sometimes we are stuck with that 1 is 16 is the critical level, but there are two ways of doing the ICT test. One is by gel method and one is by tube method. But if it is by tube method, then it is 1/16. If it is by gel method, then it is 1:64. So whenever you are in confusion, first confirm what is the critical level of that lab, that particular lab. That should be confirmed first, and then the things should be correlated. And then we definitely we should go for the serial scans to see how the fetus is progressing. If the fetal anemia is progressing, then IUT is the only answer to save the fetus.
Yes. Yes, ma'am. Fetal anasarca and decreased fetal movement are the severe most features of fetal anemia, and in
yes,
fact,
there
sign
will
of
be
impending fetal
hydrops
death.
in placenta also, and polyhydramnios also.
Yes, ma'am. Especially the fetal scalp edema, the umbilical cord edema, the fetal ascites, pleural pericardial effusion. Along with them, if there's a decreased fetal movement, even the NST also may show up, sawtooth appearance, a sinusoidal pattern. These are suggestive of severe fetal anemia, and we need to give them IUT urgently, and otherwise we might lose the baby. So hydrops is a very late feature, and fetus is already in cardiorespiratory failure. This we all should keep in mind. We should not be waiting till the features of hydrops are visible. We have to intervene early when MCA PSV MOM crosses 1.5 MOM. So I hand over this case to Dr. Krishna Gopal. Sir, are you there? Dr. Krishna Gopal?
Yes, ma'am.
How to measure MCA PSV correctly and how to calculate the MOM? What does this MOM means? And when should the patient be referred to fetal medicine specialist for IUT? And we also want to know whether the MCA PSV MOM be used in monitoring of the patients after IUT?
Yes. Good afternoon, ma'am. And thanks organizing team, particularly Sharda ma'am, Dr. Jyoti Bhaskar ma'am, and Dr. Meenakshi Sharma ma'am for making me part of it. This is an important question, and basically to avoid the inter-observer as well as intra-observer variation, we have to devise a method of doing MCA PSV. So that method was first proposed by Mr. Mari. That has he has done the pioneered work in this field, and later on all the society, including his Vogue, Fetal Medicine Foundation, all have followed it. So basically we have to measure MCA PSV in a particular way, and the way is we have to first take the axial section of the brain, including thalmi, CSV, that is cavum septum pellucidi, greater wing of sphenoid, and the circle of Willis, and we then magnify it to the 50%. And at the same time, we should make it ensure that the whole of the MCA is visualized in its entire length. Then we should do the sampling by making our angle of insonation that we call the ultrasound beam and the MCA, that angle should be zero. The sample volume should be very small, that is 1 millimeter, and the sampling has to be done in its proximal length, that is within the 2 millimeter. So if we do it in that way, only then whatever the PSV is coming, that is an accurate one. At the same time, most of the machine gives the PSV between centimeter per second. So our next job is to convert it to the mom value. So for that, there are mathematical calculations as well. But the easiest method is either you go to the perinatology.com. There's a calculator. You can easily calculate it. Or you are a member of Society of Fetal Medicine, so there is an app, Society of Fetal Medicine app. So there is a similar calculator that you can download on your mobile, and easily the centimeter per second can be converted into the mom value. We have to do it from 18 weeks onward to 35 weeks. Beyond 35 weeks, we don't do because the level is higher, and it can give the false appearance of the fetal anemia. Many workers propose it to be done by say 17 weeks also. We can do it for the purpose of not only diagnosis rather than the monitoring as well.
Yes, Dr. Krishna Gopal. Thank you for highlighting that the MCA PSV values between 18 to 35 weeks are the values which correlate best with the fetal anemia. So whenever we know that it's more than 1.5 MOM, these fetuses needs IUT. Repeat MCA PSV is usually done after 1 week, and if it second value also comes more than 1.5 MOM, then IUT should be planned for these patients. And in fact, once the ICT titer of these patients, if they are beyond the critical value, that is the time I think for the best perinatal outcome, we should be referring these to fetal medicine specialists rather than managing ourselves with ultrasound following up for hydropic features and MCA PSV, because the patient has to reach there in time, reach the fetal medicine specialist in time for intrauterine transfusions. And this is the thing which can really salvage these hydropic babies, fetal anemic babies, and really improve the fetal outcome. Perinatal outcome is definitely improved with intrauterine transfusions. I will not be going in details of the intrauterine transfusions because for most of us, we refer these patients, and fetal medicine specialists are really dealing with managing fetal anemia in these patients. And another thing I would like to highlight that post IUT, after the intrauterine transfusion has been done, and the MCA PSV is then not a good marker for monitoring of these patients, because at that time the fetal circulation, the RBCs, adult RBCs are also in circulation along with the fetal RBCs, and their waveform is different. So we need to be monitoring them depending on the fall of the hematocrit level and predicting when the next IUT is going to occur, along with the fetal movement scoring as well as the biophysical scoring of such patients, and subsequently IUTs are done. Intravascular transfusions are done with the O negative closely packed RBCs, and volume is determined depending on the cord hemoglobin along with the desired hematocrit which we need to achieve, and along with whatever the donor hematocrit is there. And once we transfuse the intravascular IUT has been done, then usually subsequently 1 or 2 IUTs may be required a little earlier. But usually after 2 or 3 IUTs, usually the fetal blood volume is replaced by usually adult RBCs, and subsequent IUTs will be delayed. So thank you all dear panelists who have really put in a lot of effort in this presentation. And just to conclude that every woman of childbearing age should have her ABO-RH typing done early pregnancy itself. At first visit, only the RH should be determined for that patient, because there can be events which can occur early in pregnancy which will determine that anti-D needs to be given. Prevention of RH sensitization in mother birth, antepartum and postpartum anti-D should be a routine practice. The use of anti-D immunoglobulin prophylaxis in sensitizing events should be used to reduce the risk of immunization further. and early referral to Rh Isoimmunized patient to fetal medicine units to improve perinatal outcome whenever we have a pregnancy with an ICT titer which is beyond critical value. All these pregnancies need to be referred to fetal medicine specialist in time. So with this, I conclude this panel, and all expert panelists can comment on this. Dr. Deka ma'am is with us.
Thank you, Meenakshi.
Thank you, ma'am. It was a great panel.